Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can rewatch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I would like to welcome our audience to today's event. I am Terry Evans, a 24-year CLL survivor and director of the CLL Society Support Network. We are joined by nurse practitioner Amy Goodrich at Johns Hopkins Kimmel Cancer Center. We will be answering questions from the audience at the end of this event. Before we begin, I'd like to share a few important disclaimers. The information provided during today's webinar is for educational purposes only and should not be considered medical advice. For any personal health or treatment questions, please consult with your healthcare team. Please note that while the CLL Society may have its own opinions and policies, our speakers may offer differing viewpoints, especially regarding the management of CLL and its complications. Now, it's my pleasure to welcome Amy Goodrich.
Good morning. Thanks for being with us here today. So we are going to be talking about Beyond Your CLL Diagnosis, a comprehensive health management. So today, with our treatment advances, the majority of patients with chronic lymphocytic leukemia will die of non-CLL causes, such as second cancers, vascular disease, infection, stroke, lung disease, renal disease, essentially other medical problems that are unrelated to their CLL. This is due to an improvement in survival for patients with CLL, our improved therapies for patients with CLL. And so many of these conditions that are not related to CLL and their risk factors can be identified with routine screening and possibly prevented or improved or slowed down. So equally as important as our CLL therapy to improving survival is the need to address overall health for patients with CLL. So let's start with infections. So as a blanket, people with a CLL diagnosis are at higher risk of infections and higher risks of severe infections. Even though most patients with CLL have an elevated white blood cell count and white blood cells fight infection, those white blood cells do not function normally. And so then people develop infections. In addition, up to 40% of people with CLL will have low immunoglobulins, specifically IgG levels, up to 3 years before a CLL diagnosis, and I'll talk about that in a second. And then others will develop a low or lowering IgG level after their diagnosis from both the disease and from the treatment of their CLL. So what is a low IgG level? Technically, it's called hypogammaglobulinemia, but IgG is an antibody type of protein that is produced by the immune system. It fights germs and it protects us from bacterial and viral infections. The thing about IgG is that they're specific to a certain germ or infection. They remember. So this is what prevents us from getting the same infection over and over again, because IgG, the memory portion of it allows our immune system to quickly attack a germ or an infection that we have been exposed to in the past. So this is a big part of our immune system. These IgG levels can be monitored with a blood test, and when IgG levels are low, people are at more risk for infections. And most commonly, they're upper respiratory tract infections like sinus infections, bronchitis, pneumonia, And in addition, because IgG creates memory, vaccine responses tend to be poor because they're not functioning normally to create that memory after we get a vaccination. So people with CLL and a low IgG level and recurring infections may have IgG replacement therapy recommended. That therapy can be given intravenously in an infusion center or subcutaneously administered by the person at home. So how can we reduce infections for patients with CLL? So if you are on therapy, if you have received therapy in the past 6 months, if you are receiving IgG replacement therapy, you really need to be discussing immunizations with your oncology team. I would encourage everyone to discuss immunizations with their oncology team in general. But if you're not being treated, you haven't been treated, your IgG is normal, it is really most likely that your team is going to recommend that you follow CDC recommendations for immunizations and boosters. And so that includes an annual flu vaccination. It includes that initial COVID-19 series and all boosters as they become available. The shingles vaccine is recommended for everyone over 50 plus those 19 and older with immunocompromise, and technically everyone with CLL has immunocompromise. The RSV vaccine is recommended for everyone 75 and older plus 60 and older with increased risk for severe RSV. And again, that includes people with CLL. Pneumococcal vaccine for age 65 and older. And then DPAT, which is diphtheria, tetanus, whooping cough boosters every 10 years. And this is not only important for the person with CLL, but those around you as well, because if you can't get vaccinated or you have a limited response to a vaccination, you are at risk for getting infected from those close to you, those you were in close contact with. So you and folks that you're in close contact with shouldn't be following these recommendations as well. What are other things we can do to reduce infections? So some of these are really common sense: hand washing, hand sanitizer. And I feel like in the post-COVID world, we're all much better about this than we were in the pre-COVID world. Masking in crowds and avoiding crowds when infection rates are high. So you've got to know your infection rates in your area. If you're going into a high risk area, really considering masking in crowds is a good idea. Also, knowing your blood counts, knowing your IgG level, those are really important things as well. Reporting fevers, shaking chills, any signs or symptoms of infection. And then if you do have symptoms, test or be tested for COVID-19, for flu, for RSV, based on the symptoms that you're having. For COVID-19 and the flu, there are medications that can be given to reduce the severity and the length of the time that infection is active. So it's important to test so that you can be treated. Autoimmune complications, these are another relatively common issue in patients with CLL. They impact about a quarter of people with a CLL diagnosis. And what autoimmune complications occur when the immune system mistakenly attacks normal cells or tissues. And again, you've got lots of white blood cells normally, they're just not functioning normally. And so autoimmune complications are common in people with CLL due to this immune system dysfunction. The most common autoimmune complications include autoimmune hemolytic anemia and immune thrombocytopenia, so low red blood cell count and low platelets from autoimmune disorders. There are a few other very rare ones, but it's these two that are the most common autoimmune complications in people with a CLL diagnosis. So treatment of autoimmune complications, so typically includes prednisone, which is a steroid, intravenous immunoglobulin, cyclosporin, rituximab. And then specifically for ITP, or that immune thrombocytopenia, TPO agonists can be used. Those are similar to growth factors. And then if autoimmune complications are not well controlled with the typical options, CLL-directed therapy is recommended. So sometimes just treating the underlying CLL, even if it's not particularly active, is what is needed to control the autoimmune complication. Secondary cancers is another issue in patients with CLL. And so these are cancers that are unrelated to the CLL. We're not talking about transformation of the CLL to a more aggressive form of lymphoma. But in people with a CLL diagnosis, there is up to 63% higher risk of developing a second malignancy than somebody of the same age and sex as you in the general population without a CLL diagnosis. So second cancers are very common in patients with CLL. In general, anyone with a cancer diagnosis is more likely to develop another malignancy in general. Because once your immune system misses one cancer, it's most likely that it has a higher risk of missing another cancer. Our immune systems are supposed to get rid of cells that don't look right. So once you have one malignancy, you're at higher risk for other malignancies. But in CLL, this is compounded by the fact that we know that your immune system is not working correctly. So those at highest risk of second malignancies are those who have received chemotherapy, male between the ages of 18 and 69, but this is definitely a risk for every single person with a diagnosis of CLL. So what are these second cancers? So the most common second cancer in patients with CLL are skin cancers. They tend to be non-melanoma skin cancers, things like basal cell, squamous cell, although melanoma is possible, which is the more serious type of skin cancer. Blood cancers can also occur, things like acute myeloid like leukemia and myelodysplastic syndrome. This is highest in patients with a prior history of fludarabine treatment. So some of you who have had this diagnosis for a long time may have received fludarabine. Those of you with a newer diagnosis are likely not ever going to receive fludarabine, but this is still a risk for everyone, these blood cancers. And then lastly, a host of solid tumors. The most common ones are prostate cancer, colon cancer, breast cancer, but really any solid tumor is possible for patients with CLL as a second malignancy. So what can you do about this? So regular screening per national guidelines. And the caveat here is it depends on your age and your risk factors, both your family history, your own health history. So there's not a cookie cutter here. This is something that you should be talking to your primary care provider about. But in really everyone should be talking about and getting regular colon screening, whether it's Cologuard or colonoscopy. And then based on those results, your GI provider will be telling you whether you should be having these done every 3 years, every 5 years, every 10 years. Prostate screening is important for the men, a good prostate exam, PSA blood testing, and then for women, breast and GYN screening with mammograms and pap smears, really just getting your good routine screening done. Because of that risk of skin cancers, skin care is definitely important. Sunscreen, avoiding high times of sun and sunburns, and then routine dermatology exams are also very important. I really like everyone with CLL to have a dermatologist and have regular dermatology exams because of that high frequency of skin cancers. In addition, for anyone who is smoking or using smokeless tobacco, there are many programs available. Some are support groups, some offer nicotine patches, some offer other medications. There are all options for smoking and tobacco cessation. And then also regular dental care, because smoking, a history of smoking or smokeless tobacco use does increase your risk of oral cancers. So really making sure that you're seeing your dentist and having a good oral exam is important as well. So other things in the end, primary care visits. So keep those primary care visits. The frequency will be based on your health history. You might be going every 3 months, you might be going every month, you might be going every year, but keep those appointments. Whatever schedule your primary care provider recommends, keep the schedule. Seeing your oncologist does not take the place of seeing your primary care provider. When you see your oncologist, we are focused on your CLL. We are not keeping track of when your colonoscopies were, when your pap smear is due, when your next PSA is due. We're not keeping track of any of those things. So your primary care provider is very important, even if you feel like you're in your oncology office all the time. We are not keeping up with your schedule for your routine health maintenance. And then, of course, seeking out medical care with any persistent or worsening new symptoms. Don't ignore things. Get things checked out if you're having new symptoms. So cardiovascular disease. In general, there is a high rate of cardiovascular disease in people with CLL, simply out of the gate, due to the fact that this is a disease of older people. And in this country, older people commonly have cardiovascular disease. So it's estimated that 1/3 of patients have significant cardiovascular disease at the time of diagnosis and before the first CLL treatment. That's not 1/3 of patients with cardiovascular disease. It's with significant cardiovascular disease. And then some treatments for CLL, namely our BTK inhibitors, do increase the risk of cardiovascular disease, specifically high blood pressure or hypertension and abnormal heart rhythms. So if you are on a BTK inhibitor or you are starting a BTK inhibitor, you may have a baseline EKG done prior to starting this therapy. We do have second generation acalabrutinib and zanubrutinib that have lower cardiovascular risks, but all drugs in this family do have this risk. And then if you do develop cardiovascular side effects, you may be referred to a cardio-oncologist or definitely to a cardiologist, depending on whether your practice has access to a cardio-oncologist or not. But definitely seeing a cardiologist is going to be recommended. So how can you prevent these cardiovascular complications? And remember, these are largely unrelated to CLL. Regular screening. So prevention with regular screenings with your primary care, all your specialists. If you have a cardiologist, endocrinologist, a vascular specialist, see all of your specialists. The oncologist is not the cardiologist. Your oncologist is not your endocrinologist. Please see all of your regular doctors. Physical activity is absolutely important here to keeping your cardiovascular health as optimal as you can. A healthy diet, weight control, also taking medications as prescribed. We tend in oncology to have people on a lot of medications, but you've got to take everything, all of the things that you came to your CLL diagnosis taking, as well as all the additional things that we may be prescribing. For blood pressure control, home monitoring, if someone's telling you to monitor at home, please be compliant with that schedule, whatever your primary care or cardiologist is telling you to do with home monitoring, please do it. Reducing stress, managing anxiety, those are very important for blood pressure control also. And then for glucose control, home monitoring, if you do have diabetes or pre-diabetes, and then really following that diabetic diet if you do have glucose issues. Bone health is another issue for patients with a history with a diagnosis of chronic lymphocytic leukemia, there are higher rates of osteoporosis and fragility fractures in people with CLL compared to the same age and gender of person in this country that does not have a diagnosis of CLL. And these fragility fractures, which are fractures with that are not that require very little trauma, these fractures are seen even without osteoporosis. And osteoporosis is low bone density, where your bones are not strong. And this is due to enzymes and other substances that are secreted by CLL that cause an increase in bone loss and a reduction in bone repair ability. This is also a function of age. And again, CLL tends to be seen in older people. So between the CLL and age, bone health is definitely an issue. When the CLL is treated, that can reduce some of the bone loss because those enzymes and other substances being secreted by the CLL quiet down. But if your regimen includes steroids, that promotes bone loss. So sometimes it's a double-edged sword, but this is definitely something for everyone with a history of CLL to be aware of. So what can you do to promote or maintain your bone health? Optimizing vitamin D and calcium levels with your primary care is important. Do not just take supplements without discussing with your primary care. There are other medical conditions that can make this not recommended, and based on your kidney function and lots of different factors, you may or may not be recommended to take supplements. So please talk to your primary care about this. Weight-bearing exercise is another way to promote or maintain your bone health. And again, if you have any bone issues, any arthritis, anything that may make weight-bearing exercise dangerous for you, this is definitely something that you should be talking to your primary care provider about. What are appropriate weight-bearing exercises for you? And that is going to look different for everyone. Bone density screening. So for females, this is recommended somewhere around age 60 or 65. It may be recommended earlier, and also for men, if you've had steroid exposure, if you have other risk factors, other health issues that also are problematic for bone health. So again, talking to your primary care provider is critical here. If you have any abnormalities in your bone density, you should be referred to a bone density or a metabolic bone clinic quickly. It's not an emergency, but you should be referred for specialized care. There are therapies that slow down your body's reabsorption of bone that may be appropriate, and those bone density or metabolic bone clinic folks are really good at working that up and making sure that you're getting the right therapies. And then there are times that physical occupational therapy, exercise physiology referrals may be appropriate, especially if you have issues that weight-bearing exercises may be difficult for you. Some of those specialties may be able to help you there too. Some of those therapy options may be appropriate. So dental health, there is very limited research in dental health in patients with CLL, but we know that folks with CLL have higher rates of dental disease and higher rates of dental treatment needs. The highest incidence is in people who have been exposed to chemotherapy. And, those of us who work in oncology, we know that mouth dryness is very common. With chemotherapy, it decreases your saliva, and saliva keeps your teeth clean. And so that's definitely part of it. But again, limited research has been done here. Strategies to reduce that risk are regular dental care, and then just keeping your mouth clean, optimizing your dental and oral hygiene. So emotional and psychological health in patients with CLL, this is another very understudied aspect of patients with CLL. So all of you know that this chronic, slow-growing disease with minimal symptoms and lots of observation, watch and wait, active surveillance, it results in uncertainty. And it's commonly not what people anticipate after getting a cancer diagnosis. Most people get a cancer diagnosis and expect to start receiving some sort of treatment. And that's not the appropriate thing for most patients with a CLL diagnosis. So this is definitely an issue. When we look at emotional quality of life surveys, they show reduced results in patients with CLL, and those results do not improve over time. So this is not an issue of less emotional quality of life at the time of diagnosis. It persists throughout someone's diagnosis. It is very common for people to be very anxious around the time of their medical visits. There's financial strain. And then again, there's really no difference, not only in emotional quality of life, but when we look at depression, anxiety, and quality of life surveys, there's no difference in these ratings in patients under active surveillance or those in active treatment. So again, these things persist regardless of what phase of a CLL diagnosis someone is in. So what can you do to improve or maintain your emotional and psychological health? So screening at diagnosis for depression, for anxiety at regular intervals, at the time of a change of treatment status or treatment initiation, early referrals to psychology or counseling, close involvement with primary care providers. Many of the considerations for medications are reliant upon your other medications, your overall health history. So, seeing your primary care provider, seeing a psychologist, a counselor, those are very important. Caregiver support is very important. Social work referrals are important. There are local cancer support services, support groups, there are peer support options for people with CLL diagnosis. So there are also CLL Society resources. And so there are approximately 40 support groups run by the CLL Society. They're held virtually in the United States and Canada. The CLL Society has support groups specific to watch and wait, specific to veterans with CLL. And then support groups are really, they're a place of camaraderie, and there's a lot of knowledge that is shared among the members. So I would really encourage both those of you with a CLL diagnosis and those of you who are caregivers to consider these support groups. And there are also there's a one-on-one emotional and spiritual advocacy program that's a one-on-one with a board certified chaplain. You can be a person of faith, you can be a person without strong faith, but it really helps explore coping mechanisms, spiritualism, meanings, making goals of care conversations, grief support, all sorts of good things. And then there's a peer support system, which is a one-on-one with an individual impacted by CLL. And that peer support volunteer is really good at sharing their own experiences, helping you navigate watch and wait, insurance, the right questions to ask, making treatment decisions, side effect management. So these are really good support programs that the CLL Society offers. And I would encourage all of you to take advantage of those as well. And that's my last content slide, and I am happy to take questions from the audience.
All right, thank you, Amy. That was a very clear and informative discussion about CLL and our journey. And we will be answering questions now from the audience, and we'll try to get as many as possible. But if we aren't able to get your question answered for any reason, please email the Ask the Expert email address after this event. And at the end, I'll share that email address in our closing slide. And we'd also like to thank everyone who submitted questions in advance. That really makes our job easier to know what your concerns are and also allow us to dig a little bit deeper into some of the questions that get asked. So with that, I'd like to begin with the questions. And so the question I have, I'm going to start from the very top. We so far have 36 questions in, but I'll actually ask the questions that were submitted ahead of time. So is low sodium typical in CLL? Does it explain an increased frequency of foot and leg cramps?
So the answer to that is yes to both of them. So all hematologic malignancies patients have an incidence, a higher incidence of hyponatremia or low sodium. This can be due to the medications that you're taking, the cancer medications, your regular medications, if your lipids, your cholesterol, your glucoses, if those are not normal, there are so many things that impact sodiums, kidney disease, liver disease, infections. There's a huge list of things that impact sodium, but even in people who do not have any of those, if you have a hematologic malignancy, you have a higher incidence of hyponatremia. This is really not well understood. The person who asked this question said that they eat salty foods for those cramps. And yes, eating salty foods, if that helps your cramps. I also recommend that people stay well hydrated, eating those salty foods, and then making sure that your potassium and magnesium are also normal, because those can contribute to those cramps as well. So just salty foods, good hydration, and making sure that your potassium and magnesium are in normal ranges are what I recommend that folks do. We used to be able to give quinine for cramps, and the FDA took that off the market. The only way you can get quinine is with tonic water. So I tell folks get some diet tonic water too, if they like tonic water. That's a good way to get some hydration in, and that helps those cramps as well.
Okay. The next question has to do with weight gain, and specifically asked about acalabrutinib, but I'd like to broaden that question to all BTK inhibitors, since a lot of them operate the same way. So is weight gain something that's common within BTK inhibitors?
Yes, weight gain is a side effect of all BTK inhibitors. And the best working theory about why that happens is when CLL is active, you have wasting, muscle and fat wasting, because the CLL is taking so much energy and is secreting enzymes that, like, literally you're losing your body mass. And then when that gets turned around and the CLL gets treated, that stops. So that's really part of it. There is not, some patients, very rarely can people actually have some fluid. It's usually not fluid accumulation. It's literally just weight gain. And the best theory is that your body, essentially eating itself, using your body's stores as energy, goes away when you get treated. And so really this person who asked this question said, I eat a healthy diet. Definitely exercising is important there too. So really just watching diet and exercise, but that is a very, very common known issue with BTK inhibitors.
Okay, next question has to do with fatigue and just general energy levels. But we know that on the onset of beginning before treatment, sometimes fatigue plays a role in determining whether or not a patient is going to need treatment or not. So the question is, if I begin treatment, are my energy levels going to increase, and is my fatigue going to lessen?
Yeah, so if your fatigue is truly solely from your CLL, you should feel better. The slippery slope there is that most people with the CLL diagnosis are older and have a host of medical problems, many of which can cause fatigue. Sometimes it's really hard to flesh out, but if it's really truly from the CLL, you should feel better. The other thing that I always do when people have profound fatigue is making sure that, your thyroid level is normal, your B12, you're, doing some vitamin and electrolyte levels to make sure that there's not a deficiency somewhere. Also contributing to that is important, but also your other health problems. But yes, if it's really from the CLL, you should feel better. Exercise also helps fatigue. It's sort of counterintuitive, but the more active you can stay, you can sometimes overcome that fatigue or have it be at minimized with exercise.
Okay. You touched on this a little bit on your slides about the bone health. And so the question is specifically, does bone health treatments lower your immunity?
So this person actually put a reference in there, and I looked at that reference, and there in the lab, it does look, when you put blood from people with CLL together with these bone health drugs, these osteoporosis therapies, it does appear to make the CLL a little more active. That's in the lab. And we all know, those of you who've ever looked at a study, you know that there are a lot of things that happen in the lab that don't equate to what happens in reality. So this group, it was an Italian group, they recommended that in future clinical trials that be an endpoint, that be watched and start to collect that in clinical trials, where you're really going through the list of everyone's medications. And so they're not suggesting that people with osteoporosis do not get those therapies. They're suggesting that we should, as scientists, our thought leaders should really be looking into this in real people as we're doing trials.
Okay. I'm going to go now to the questions that were submitted today. And I don't know if there's an answer for this one, but what is the average age that CLL patients require treatment? We know the average age of diagnosis.
So, right. That, you know what, that depends on your prognostic factors and how fast your disease, progresses after you get that diagnosis. We know that, I mean, I've never seen data. So that's a great question. I don't have an answer.
Yeah, I mean, it's in our support groups, it's all over the map.
Yeah.
Age-wise of when, and you're exactly right. It really has to do with their CLL specifically. That's why CLL is such a heterogeneous disease that, you can't really necessarily predict the future when you might start treatment. So
yes, there's no cookie cutter.
No. So this one says, does the Captivate data at ASCO make retreatment more compelling? And is there any specific patient profile that retreatment is more suited? And is there an increased interest in BTK BCL2 combinations because of retreatment potential?
So that's the $1 million question, right? And so so we know what happens when we give these drugs sequentially, right? That you get a BTK inhibitor and then you get a venetoclax-based therapy, or the other way around. We know what happens. We don't know what happens when we put those drugs together, and how people are going to respond down the line. In my clinical practice, we tend to repeat the venetoclax. I know that's not standard. There's no cookie cutter. Again, that is a great question. And I think time will tell. So in these trials that combine a BTK inhibitor and venetoclax, they are keeping track of who's treated with what next and how they do on that next therapy. And the good news is people are doing really well on these regimens and stay in remission for a very long period of time. So it is going to take a long time for us to figure out what the best strategy is moving forward. And it may be different for people with a 17p deletion than it is for people without a 17p deletion, or what your IGHV status is. We don't know. I always say studying CLL is not for people who are impatient, because it takes so long to figure out, the right course after a study like this. But it is a great question. You're ahead of your time.
Here's one from an untreated patient. My white count has jumped from 29 to 49 in less than a month, and I'm having quite a bit of bruising. Is the bruising a bad sign? I would go back to, is the increase in the WBC a bad sign? But put both of those together maybe.
So the bruising, I would want to know what your platelet count was, right? So there's really no magic white blood cell count for treating CLL. The issue is that as your bone marrow gets so packed with CLL cells, you start losing your capacity to make other normal cells, really. Neutrophils are the big ones. People can become neutropenic, you can get anemia, your hemoglobin and hematocrit can drop, your platelets can also get low. So that bruising, I would wonder what your platelet count is. The 49,000 white blood cell count is not an automatic trigger. Going from 29 to 49 is not an automatic trigger to do anything. But if your other cell lines are dropping off, that may be an issue. So you should definitely report that bruising and get some labs done and get seen. And
it's really the trend more than one test as well.
Never get excited over one value. We want to see a trend. Infections, medications, other illnesses. There are so many things that can make your counts go crazy. And then, the next month you get them checked again and they're back to what they usually are, closer to where they usually have been. But any sort of illness, new issues, new drugs, hospitalizations for anything, you get a knee replacement, anything can set those counts off. Yeah.
Okay, this one kind of opens up a door really for the question of continuous therapy versus a fixed time therapy, and but the question centered around what is the primary reasons for using a venetoclax based regimen, and are there any patient profiles that seem to fit that more than a BTK?
Okay, that is a great question. And okay, so when I talk to patients about these regimens, it's really about what fits into your lifestyle for most patients, whether you want just to take a pill as long as it's working versus the venetoclax and obinutuzumab, where for the first couple months, there are really a lot of visits, there are infusions, but you're done in a year, okay? So for the average patient, it's really about what fits into your life. Aside from that, patients with a 17p deletion or unmutated IGHV status tend to have better responses to a BTK inhibitor than a venetoclax with an anti-CD20, okay? But today, if you started a BTK inhibitor, you have those prognostic factors and you started a BTK inhibitor. Today, if you were progressing and needed treatment, you would get a venetoclax-based regimen. So to me, it's more about what fits your lifestyle and what regimen you're going to be adherent to more than anything else. Because really, at some point, if people if you get treated twice, if you're diagnosed today and you get treated twice, you're going to get a BTK inhibitor and a venetoclax-based regimen. These are just the best drugs that we have, even though those folks with 17p deletions or unmutated IGHV status do tend to respond better to BTK inhibitors.
Right. here's one that actually comes up in our support group sometimes. People are doing well on, let's say, ibrutinib, and now they realize their doctor is no longer prescribing ibrutinib as a first-line treatment, and so they ask the question, well, should I switch to acalabrutinib or zanubrutinib because they have less adverse events? And I know my medical team said that, if you're doing well on ibrutinib, they don't see a reason to really change. It's when you have issues that they can't manage, then they would look at possibly changing. But in your practice, would you look at changing a patient that's on ibrutinib to something else if there were really no adverse events?
Yeah, no, we're not switching. If you're tolerating it, they're all good drugs. They all work very well. And if you're tolerating it, there's no reason to switch. There was an update to the NCCN guidelines this year that also, it was based on data about dose reductions, that you should do dose reductions before switching agents as well. And there's a lot of data showing for ibrutinib, acalabrutinib, those two especially, because there are older ones, that dose reductions do not impact the efficacy. So, if you're having side effects, even then, dose reduce is what the NCCN guidelines say before switching agents. So yes, just if you're tolerating it, just feel comfortable that that is the right thing.
I've also read that for somebody that has been on ibrutinib, let's say for 2 or 3 years, the dose reduction has less risk at that point if they have stable disease, correct?
Yes, then doing it early, right?
Early,
Yes, of course,
right.
yes. Yeah,
Okay,
definitely. Thanks for saying that, Terry.
okay. Let's see, this one's getting a little out there, but in high-risk patients, thoughts on using bispecifics as a consolidation therapy if MRD on completion of a combo therapy of BTK plus BCL2. So
That would have to be done on a trial. That is not FDA approved. And
correct.
I'm actually, I mean, there are bispecific trials going on in CLL. I don't know if the criteria are exactly what you're saying, but there are bispecific trials, and I would encourage everybody to look at those because they had been really promising in many other diseases, and are
Right.
FDA approved for many other diseases.
Right. You kind of answered this before in the fatigue question. It says, why so long after treatment do I still feel fatigued? My treatment was in 2011. It was stage 4. I assume they're doing well now, but why do they still feel fatigued?
Yeah, I would really ask what your other health issues were, what your other medications are. The other thing is, 2011 was a long time ago now. I'm not sure any of us feel like we did in 2011. I know I sure don't. And that's another thing, that's 13 years ago. But really looking at your other health conditions, your medications, what are your blood counts doing? Do you have anemia? Those are the things I would be asking.
Right. Not everything is CLL. We tell patients.
Right.
Do you recommend IV vitamin treatments for general overall health for CLL patients?
So I am not aware of any studies that have found that to be impactful for the disease itself. There are lots of clinics out there doing vitamin and, different infusions. I don't object to people doing that, but that's not something I steer people toward. I think if you take a multivitamin and your vitamin and mineral levels are good and you're eating a good balanced diet, when we get a lot of those extra vitamins and minerals, we pee them out. Your kidneys just send them, out in your urine. So I'm not sure there's enough data right now I know there's not enough data to recommend that.
Right. I think this was misspelled, but it says, is CIDP a complication of CLL?
Common immune deficiency, common
Yeah.
CID, I'm blanking, CIDP. Common immune deficiency. Hang on a second.
I was wondering if it was COPD.
CIDP. Yeah, common immune deficiency. Common immune, chronic inflammatory demyelinating I knew that wasn't right, what was coming to my head. Polyradicular neuropathy. That is an autoimmune disorder. And we know that people with a diagnosis of CLL have a higher incidence of autoimmune disorders, but it doesn't go the other way around. If you have an autoimmune disorder, that does not predispose you to CLL. All autoimmune disorders have a higher incidence in people with a diagnosis of CLL. So yeah, that's that's definitely on the list of things that are possible. I did talk about the hemolytic anemia and the ITP. Those are really the most common ones, but I've got lots of patients with all sorts of autoimmune disorders. Yes.
Okay. We talked a little bit about IVIG, and the question here is, how long after IVIG did the levels increase or peak? I guess maybe to just expand that and say, what's the half-life of IVIG and
Right.
how often do you
So
get
we
it?
know that if you're getting monthly IgG infusions, it spikes up, and by the time you get your next infusion, it's gone. We have actually stopped giving IV IgG. We give the subcutaneous products. There are a couple of them that are self-administered at home, and those flatten out the curve. So you don't have all those peaks and valleys when you do subcutaneous. So we have stopped doing intravenous immunoglobulin because of that. Our immunology team feels very strongly that the subcutaneous route is the way to go to not have those periods where your IgG is rock bottom again.
Right. And it saves you a trip to the infusion center.
Yes.
And
Yes. I mean,
4
no
hours.
one really likes self-injecting, but they really love not being in the
Yeah.
infusion chair and getting IVs put in and all of that. It's really much easier to eventually people realize that this is really a much more convenient way to do it. Yeah.
Right. So following up on IVIG, should vaccines be timed to follow IVIG infusions?
So if you are on IV IgG, you do not, there are certain vaccinations that you should get your flu shot. If you're getting IV IgG, you are not going to respond to a COVID vaccination, but you're getting COVID antibodies in your IgG product. You should be talking to your healthcare team about vaccinations if you're getting IV IgG. For sure, if you're on treatment, if you've had treatment in the last 6 months, it needs to be your plan needs to be customized. But in general, flu shots are recommended sort of blanket. COVID vaccinations may or may not be appropriate. If you're on IgG, our immunology team tells people don't get the RSV vaccines, but that's just, everybody's going to have a unique situation.
Yeah, ask your medical team.
Ask your medical team, but if you're not getting treatment, you're not getting IgG, which is going to be most of the people on this webinar. If you're not being treated, you haven't been treated in the last 6 months, you're not on IV IgG, you should get every vaccination that you're eligible to receive.
Correct.
Yeah.
Yeah. Okay, one more. IVIG seems to be a hot topic today. I was given prednisone and Benadryl, but developed an entire body rash after my second IVIG infusion. My dermatologist said it was the prednisone with a low immune system that caused guttate psoriasis. Is there something else I can do to replace IVIG infusions? Let me just say, I've been taking IVIG for a number of years, And all of a sudden, during one of my infusion, I developed hives. And I went back and checked, and they had changed brands of IVIG on me. And it was the only time in all those years that they had used a different brand. And once they went back to the old brand, I never had a reaction again. So it could be the branding, but then I'll let you answer the question in terms of a
Right.
replacement.
Well,
for
the prednisone, if your dermatologist really thinks that the reaction was from the prednisone, that prednisone is really the most critical for that first dose, and you may really not need the prednisone moving forward if that was the problem.
Right, right. Okay. Okay, prophylactic shots for COVID for, you know, we have Pengarda now, which is an infusion, but it is not an IgG infusion. It is a infusion where you go in and you're monitored for an hour or two afterwards, giving you some prophylactic protection from COVID. And is this something that you see common in your practice?
So we're not giving a ton of Pemgarda. So this replaced Evusheld for those of you
Correct.
who had received Evusheld. And so when folks are talking, when we have these discussions with patients, I'm always checking their antibody levels first, or their spike proteins, to see if you have immunity, right? So if you have immunity to COVID, you didn't need Evusheld back in the day when we were giving Evusheld, and you really don't need Pemgarda if you have immunity. If you don't have immunity, then yes, that is in my practice, then that is reasonable. What we find is that people have been vaccinated over and over and over again, and even people whose immune systems we know are not working well at all do have low level antibodies. And so the real goal here is that if you have antibodies and you've been exposed to COVID and your immune system knows that you've seen COVID before, you can mount some response if you develop COVID. And so that prevents, hospitalizations, and certainly is why, our mortality rate from COVID has been slashed. And that really does apply to the CLL population as well. If you have immunity, you're good. If you don't, then Evusheld was appropriate and Pemgarda is appropriate.
Okay, here's one. Is there a relationship between IgG and neutrophils?
There is not, because IgG is the end product of lymphocytes. So that's a lymphatic family cell, and neutrophils are more myeloid. So yeah, they're totally different families.
Okay. You answered some questions about autoimmune complications, ITP and AIHA today. So I think that question has been answered. Do all white blood cells not work properly with CLL, or are there a certain percentage that don't work properly depending on stage?
It's the lymphocytes that don't work well. They appear mature under the microscope, but functionally they're very immature. Your neutrophils, your eosinophils, your other types of white blood cells, they're fine. Yes, that's a good question.
Okay. This is a COVID question. Should I be concerned about visiting family that have not taken the COVID shot?
I would ask you if you had antibodies, right? If you have antibodies and you can protect yourself, then you have to just do what you feel is right. I really encourage people to really mobilize their family members and, encourage them so that they don't give it to them. But if you have immunity, you're probably okay.
Okay. Talking about fatigue and sleepiness again, can a stimulant like Adderall be prescribed to offset this?
That's really a last resort. Yes, I have had people on Ritalin, Adderall, things like that. They have very variable results. I would be looking for every single cause of fatigue before I started those. If you were, somebody I was seeing.
Okay. I developed urticaria last year with no environmental triggers. Could it be an autoimmune response from the CLL?
That's a hard question to answer. We do know that people with a diagnosis of CLL have hyper responses to like bug bites, to things that do cause skin eruptions. We know that their skin eruptions tend to be pretty significant. So it could have been. I'm saying it could have been. I would need a whole lot more detail, but yes, that is possible.
Okay. We get this question a lot in our support groups about when you're feeling ill, when should you make that call to the doctor's office to say, I would think I'm having something going on here, and can I come in and see you? So what are the triggers that would generate the call to your doctor?
Well, they're really very variable. So I'll use the example, we got one of our pre-questions was somebody saying that they've been very short of breath for the last 3 weeks with any activity. They're very short of breath. Immediate. You should be reporting that. If you have a cold and it hasn't been a week, you're not blowing green or brown stuff out or coughing green or brown stuff out, you're not having respiratory difficulty, writing minor things out does make sense. But if you have it, especially if you're on treatment, if you're having new symptoms that you can't control with the drugs that you have at home, don't wait a week. Call. And it may be that they say, okay, well, do this and wait 2 or 3 days and then update us again. Especially if you have a portal, shooting messages through those portals and just saying, hey, this is going on. I'm really not sure this is an issue, but it has me concerned. That's definitely a good option. You can always pick up the phone and call, but if you're really just having something mild that you're worried about, shoot a message through the portal. If there's something that you are really concerned about, pick up the phone and definitely call. The breadth of things that could happen it's too extensive to even try to cover all of the things that you should call for. Yeah.
This one has to do with platelets and baby aspirin.
Mhm.
Is a platelet level of 140 concerning if I'm taking a daily baby aspirin?
No, not at all. No, not at all. No, your platelet count has to get well below 50 for a baby aspirin to cause issues. Yeah, that's a good question.
Okay. I think this is a cardiovascular physician question, but there was a study done in 2023, the role of cholesterol in chronic lymphocytic leukemia. And is there anything I can do to lower my LDL? So
Diet, exercise, medications. Those are the, yeah, those are the, again, just keeping everything that you can under control, well controlled is really important in folks with a diagnosis of CLL.
okay. We just had this question this month in our support group meeting about dental health. Someone was having a implant done, somebody else was having a root canal, and the question came about doing prophylactic antibiotics before a major dental procedure, not necessarily a cleaning, but something like a root canal or something where they have to do an implant with a bone graft. So is there a recommendation for antibiotics before those types of major procedures?
So as someone who's had bone grafting done, I got antibiotics. I do not have CLL. So if you're having a major procedure, you are going to get antibiotics and you should get antibiotics. The real question is, what's your platelet count? What's your neutrophil count? You know, just making sure that there aren't going to be additional issues. But for those big procedures, the dentist is prescribing antibiotics and you should absolutely take them.
Okay. Here's an interesting one, because you hear this all the time. Even IVIG, they have labels on it that say chemotherapy. But it says they keep hearing about chemotherapy and how bad it is, but is obinutuzumab and venetoclax treatment considered chemotherapy?
It's not. So venetoclax is it's a BCL2 inhibitor. It's a targeted oral drug, and obinutuzumab is a monoclonal antibody. Chemotherapy, it typically what patients with CLL could potentially get. I actually can't remember the last time I had a patient with CLL get chemotherapy, but things like bendamustine, fludarabine, cyclophosphamide. These are probably drugs that most of you have not heard of because we're just not using them. We have drugs that are more effective and significantly less toxic.
Yeah, yeah.
But everything is called chemo, right? And like when
Yeah.
when you go to an infusion chair, they like the way they get scheduled, it looks like you're getting chemo. It's sort of it's a real misnomer, but yes, you're probably not getting chemotherapy.
Right, right. This person is having trouble getting routine dermatology screenings because they say don't make an appointment unless you have an issue. I know for myself, I'm seen every 6 months by my dermatology team, and most of the people in our group have regularly scheduled appointments with their dermatologist. Now, this person is in Canada, so maybe their way of dealing with dermatology is different, but I think it's mandatory for CLL patients to have skin checks because of the issues coming up with, dermatology cancer. So I don't know what we can offer to this person.
Yeah. I would ask if your dermatologist is aware that you have this diagnosis, because skin cancers are the most common second malignancy that people with a diagnosis of CLL develop. So I like everyone to have a dermatologist and see them at least once a year. You know, depending on what they're seeing, you may be every 6 months, you may be more frequent than that.
Yeah. They ask, are there specific published guidelines? And I would just do a search on, um, uh, you know, dermatology, cancer, and CLL. And
Yeah.
I'm sure you're going to get
Yeah.
a ton of articles about that,
Yeah.
specifying
Yeah.
that the fact that we as CLL patients, are more likely to have skin issues than the normal population. So just take that with you and say, hey, this is why I'm concerned.
Mhm.
And this is why I want to be checked. I mean, that would be my recommendation.
Yep, I agree. But part of it in the United States is that if you don't go frequently and you have a problem, you can't get in. It may be different in Canada, right? That with
Correct.
specialized medicine, it may be different. I would recommend you talk to your dermatologist and just make sure they are aware of this increased risk of skin cancers in people
Yeah.
with CLL diagnosis. Yeah.
I like the start of this question. It says, silly question. Well, number one, believe me, no question is silly, but I'm not sure everybody knows this. Can a CLL patient donate blood?
No, you cannot donate blood. Don't,
Right.
it's a great thought, but no, you
It-
can't donate blood.
Right.
Anybody with I mean, really anyone with a malignancy, a recent malignancy or a blood cancer, that you would screen out.
Yeah. Right. Let's see. Is there a frequency set up now for RSV vaccinations?
Today it's a one, it's
One time?
you get one, yep, it's a one-time
Yeah.
series, yeah.
And follow that up. Is there a frequency schedule for COVID vaccinations?
Well, it seems like we're getting a new one every fall that's covering the new variants. I know that the new ones just came out, like in the past week or so, they've been available here in Maryland. But prior to that, pharmacies weren't even stocking the old one, and they were waiting to get the new batch in.
Yeah, yeah. Here's one. Should I get a pap smear? I'm 79 years old and have not had one in 10 years.
You should talk to your GYN and your PCP. A lot of the pap smear frequency is based on your previous findings, also based on age. So definitely needs to be customized to you, but that's a great question. Yeah, ask the questions of the people who are taking care of you, and they'll guide you in the right direction.
Right. This one comes up a lot and people are confused about live vaccines. And we know that people can't get live vaccines, but could you just give a couple of examples of vaccines that are very common in the normal population that we
Yep.
could get?
So when I think about vaccines and all the vaccines that you could potentially get, I think about people who've had bone marrow transplants or CAR T, and they repeat their immunizations. And they get all their baby shots over again. They get COVID vaccinations over again. They get their shingles vaccines. They get everything. The only live one is MMR, measles, mumps, and rubella. That's the only common live vaccine. Now, if you're traveling overseas and your health department is recommending other like one-off vaccinations, you need to ask about live vaccines. We do give patients, it's at the 2-year mark after the transplant or the CAR T that we give the live vaccine. And so if you need a live vaccine, you should be asking your oncology team whether or not it's safe for you. When the shingles vaccines were live, the first shingles vaccines that we had were live. We did not have patients get them, and the ones who did often developed shingles. That's the issue. But since they're not live anymore, we do recommend that everyone get those. But MMR is really, in terms of the common ones that you think about when, your kids or your nieces and nephews got their vaccinations, that's the one that's live. And we're not getting that repeated.
Right.
Yeah.
Right. Okay. Let's see. There's a lot of questions about bone health here. There's one about can enzyme supplements be beneficial to counteract bone loss? Here's another question about there are many different therapies. Some are hormone-based and some are not. Which one would be the best for CLL?
So there is very little research on this specifically in CLL, but I know that the drugs that get recommended really, it's driven by the level of your bone loss. Do you have outright osteoporosis? Do you just have osteopenia? I would really recommend that if anyone is worried about their bone health, if you've had bone density studies done and they're not normal, you go to one of these bone health clinics. These folks who do this is their life's work doing this. And they're very helpful, and they will just steer you in the right direction. That is definitely something that is customized, and it's based on also your kidney function and other medications that you're on. There are a whole host of factors that go into which of these bone health drugs are recommended and why.
Okay. We see this question a lot on the forums, and there's wide varieties of answers. But how bad is it to have a glass or two of wine a week with CLL? I am now in remission, but my IgG is low.
So what I tell people, if you're not getting treated and your liver function is normal and everything is normal, a drink or two a week is really not likely to hurt anything. I would recommend that you just ask all of your health providers that. I don't know what medications you're taking, what other health problems you have, but, in general, if you don't have a whole host of health problems, are not on a lot of medications, very modest drinking is generally okay.
I'm currently on zanubrutinib, but I have to take prednisone steroids for 1 day. Is that a problem?
You know, that's fine. Yep, absolutely fine. Yep.
Okay. I'm confused about my IGVH status changing from mutated to unmutated, and I've received conflicting information.
Well, that is a rarity that those change. So it's almost more likely that one of those lab results was wrong than you actually change your status changed.
Yeah.
Yeah, the incidence of a lab error is higher than truly having someone switch.
Right.
And I don't know if you had one done sort of in a, I don't know whether it was the same lab that did them. Your oncology team should be able to tell you which one they think is the keeper. And if there's any question, you can always have it done again.
Right. Right. Yeah.
Yeah.
I've often heard that it was just incorrectly read, depending on where you had it
Yes,
tested. And if it's at a major medical center or educational center, more than likely it's going to be more accurate.
correct.
So yeah. Okay. Can taking a variety of medicines, including heart, gout, bladder, have an effect on a CLL patient who is also on, they say chemo pills, but a
Yeah.
calsequence?
Yes, so all of the oral therapies, ibrutinib, zanubrutinib, acalabrutinib, pirtobrutinib, venetoclax, all of the oral therapies have drug-drug interactions. There can potentially be problematic drugs. And that is why it is so important that every time you see your oncologist, really knowing what you're taking, not just prescription medications, but over the counters, herbal, supplements, vitamins, all of those things. Most oncology practices today have a pharmacist embedded in them, and there are people going through your medication list and making sure that you don't have any of these drug-drug interactions. If you do, the dose of the oral therapy that you're on for your CLL is often reduced, because it's common for other medications to have the concentrations of the oral drug that you're getting for your CLL make them falsely high. So you may need dose reductions. I would just recommend that you really include every single thing that you're putting in your mouth and not just your prescription medication, so that your team can dose modify or be aware of those drug-drug interactions.
I don't know if can be answered, but how long is the average time that it takes for white blood cells to decrease using Brukenza? So let's just put all the BTKs in one category.
Yes. So that's a great question. One of the things that happens when people start a BTK inhibitor, part of the way they work is they actually shrink lymph nodes first, and the lymphocytes in your lymph nodes get pushed out into your bloodstream. And about 50% of people who start a BTK inhibitor will have a spike in their lymphocyte count. But you'll see your nodes shrinking. And then, so some people who have that spike, it may go down a little. Some people have an elevated lymphocyte count the entire time they're on the BTK inhibitor, and it's not indicative of a lack of response. So that's sort of how the drug works with lymph nodes. But in general, if you didn't have that spike, most people within the first 2, 3, 4 months are going to have a really nice downward trend. Not everybody gets down totally into normal ranges. So you might sit above normal, and as long as it's stable and your lymph nodes are under good control and the lymphocyte count is stable, they don't have to get to normal. We know that BTK inhibitors do not induce deep remissions, which is why they're open-ended, why you take them as long as they're working. We know that if we looked for CLL in your bloodstream, the average person who's on a BTK inhibitor, we can find it. The CLL is there, it's under control. It's in remission, and those remissions can last years and years and years and years, but they're not getting people in deep, deep remissions. So as long as your white count is stable, it trended down and then it stays stable, that's okay.
This one's pretty easy. What is considered a retreatment?
Retreatment is when you repeat a therapy that has been used before. So someone talked about ibrutinib with venetoclax, the Captivate study, and even with venetoclax and obinutuzumab, patients can get treated again with venetoclax-based regimens and do well. In the solid tumor world, that is really rarely done because people, once they stop responding to something, they don't respond, they don't respond again. But in CLL, we can go back to some of these treatments that aren't toxic. Now, when we only had chemotherapy, we didn't go back to chemotherapy, but with these targeted drugs that are well tolerated, we can go back to them. That's retreatment.
Should blood sodium levels be checked regularly?
So when you're getting a comprehensive panel, that's getting checked, and that's a very frequently monitored lab for people with CLL, a comprehensive panel.
I see this question all the time when patients are in treatment and they get to undetectable MRD, and then they say, well, so now is my immune system going to recover?
You can have undetectable measurable disease and have low IgG levels. They don't go hand in hand. If your neutrophil count recovers and your IgG levels are good, then your immune system is in good shape, but they don't have to trend that way together. The neutrophils and the IgG levels don't have to trend together.
Okay. Bone pain. Is bone pain an issue with CLL? And is there any treatment for bone pain?
So I have a whole lot of questions there. So on treatment or off treatment, with growth factor, without growth factor. So yes, bone pain can be seen with CLL. It's not a common disease related issue like it is with the acute leukemias, where the bone marrow is those cells are overturning every 24 hours or every 12 hours. Those people have a lot of bone pain. CLL, because it's chronic, there's not as much bone pain. That's not a hugely common issue. It can happen. But many of our treatments can cause bone pain. Certainly the BTK inhibitors can cause bone and joint and muscle aches and pains. And we know that if people get pegfilgrastim or Neulasta or any of those growth factors, those cause bone pain as well.
Right. What about getting supplements like IV iron or B12 shots?
So if your levels are low, yes, getting those supplemented, yes, is perfectly adequate. Yes. And there was an ASH abstract, essentially promoting more IV iron use in patients with low iron levels. Many times with CLL, it's not iron deficiency anemia. People are anemic because their bone marrow is not making red blood cells. It's not because of iron deficiency. So I don't want everybody out there to start iron infusions, but if you do have an iron deficiency, iron infusions may be appropriate, and other B12 as well if your levels are low.
This one applies to probably a lot of people. Is there a problem with drinking coffee?
I would never tell anyone not to drink coffee. No,
Okay.
unless it nauseates you, unless it gives you like terrible heartburn. If you're on a BTK inhibitor, they can cause diarrhea. So sometimes, the coffee will aggravate GI symptoms or you know, everybody's different, but I don't blanket tell people not drink coffee.
So let's carry this one step further. And what about energy drinks?
Oh, oh, um, every single thing that I've seen on those, say that they're horrible for you. There's data coming out that there's cyanide in them, like they're not, I don't recommend energy drinks.
Okay.
Yeah,
Somebody asked about a medicine that they can have on hand if they get the flu. And I believe that's Tamiflu.
mhm.
And do you guys prescribe Tamiflu to people to have on hand?
We do not prescribe it to have on hand, because we want people to be tested and make sure that you have the flu and, you know, go to your urgent care. And yeah, Tamiflu is definitely appropriate if you do have the flu, and Paxlovid as well if you develop COVID. And
Right.
they're effective if they're given quickly. So, you know, if
Right.
you're having, you know, upper respiratory infection or symptoms, for more than a few days, get tested. You know, if you have a COVID test at home, test, you know, go get tested for flu so that you can get those, their antiviral medications that limit the severity and the length of time that you have symptoms.
This person was asking about the blood donation question again. If they are in remission, can they donate blood?
No.
It's
No.
same situation.
Yeah.
Right. Yeah. We are getting really close to the end of the event here, and I just want to quickly go through and see if there's anything that is real that we could answer quickly. Let's see.
I know there are a lot of people on here, Terry, and I want to say to everybody, I wish I could have gotten to all your questions. Write
Right.
them down, take them with you. Ask everyone every question you have, your primary care, your oncologist, if you have cardiologist, vascular, your endocrinologist, write your questions down and get your questions answered everywhere you go.
Right.
You
Right.
deserve answers to every single question that you have.
Right. Right. There's a question about the person had shingles and says, should I still get the shingles vaccine? And I believe the answer to that is yes. After the shingles has passed, you should still get the shingles vaccine because it's shown to be very effective. I've had shingles 3 times, and
Yes.
it is not fun to go through, believe me.
Yes.
So let's see if I can get to is there any relationship between blood type and CLL, like A or B or O or?
There's not.
Okay.
There's not.
Okay. All righty. Let's see. My dermatologist wants me to do dermatherapy, photodynamic therapy to clear up my face from precancerous growths or growths.
Mhm.
Do you think that that is okay with CLL?
Yes, I do. Yep. And
Okay.
the only time that those things are not okay is if you're on active therapy, if you're on treatment or you've just finished treatment. It's worth asking your oncologist if you should wait, you know, a few months. But
Okay.
you're not on treatment. Yep.
All right, Amy, I think we've reached the end of our time here, but I want to ask you to provide any closing thoughts you have for our patients and caregivers that have joined the session today. We were up well over 350 people at one point.
Yeah, that's wonderful. I thank you all for being here. Again, write your questions down, see your specialists, keep yourself healthy. It is not just about your CLL. And also, please understand that when you go to see your oncologist, they are not thinking about when you had your colonoscopy, what your cholesterol level is, when you had your last PSA. We're not thinking about that at all. We are laser focused on your CLL. And so it is all your other healthcare providers that are keeping all these other systems healthy that we've been talking about. And there are more. We just touched the tip of the iceberg with the health maintenance. But
Right.
just because you're seeing your oncology team all the time does not mean you're getting comprehensive health care. So,
That's a great point.
Yes.
That's a great point.
Yeah, but thank you everyone for being here, and thank you, Terry. And I just want to thank the CLL Society for organizing this as well.
Well, you gave a great presentation today, and I want to thank our generous donors, AstraZeneca, Beijing, and Genentech for helping us provide programs like this for CLL patients, because they're always usually very, very well attended, and I think very informative for patients. And so I think that we really appreciate you coming to this. We'd like to have you fill out the post-event survey to know what we can do better, or what topics you would like to see more detail on. If you have questions that you really want an answer to, you can send an email to asktheexpert@cllsociety.org. And then those questions can get answered to you specifically. Join us for our next webinar, which is Getting the Most from Your CLL Treatment, Managing Side Effects, and Knowing When to Stop, which will be on October 16th. And the CLL Society has invested in your long life. Please invest in the long life of the CLL Society by supporting our work. And we want you to be strong. And as Brian says, we are all in this together. Thank you very much.